and stop sharing my screen. Might be on mute.
Sorry. I'm going to pass that right off to Kara, and hopefully, yeah, there, Kara, you didn't make my mistake. You unmuted yourself well ahead. You're in a perfect position, I think, to answer a soft, not to answer, but to reflect on a soft financing question, because both in your state role in Delaware and now working for a combination fairly unique of a foundation and a delivery system, there's not necessarily the ability to move money back and forth, but you can certainly see the flow going, the money flowing in different places. So reflections on this as you go through your presentation, reflections on this redistribution question, both from the state vantage point and from a foundation and delivery system. Thanks.
Thank you so much, Chris, and thanks for the opportunity to present some ideas. Next slide. We at Nemours Children's Health System are trying to think through how we do this work, and we're kind of a unique organization, multi-state, multi-site, and we're a hospital, but we have clinical primary care services, and we really are trying to figure out how to go beyond health. But that is challenging for all of the reasons that have been articulated both today. I think it is monumental that we're in a period of time when we're really trying to capture the thoughts around community health and health equity on today, the day of George Floyd's death, when we really are trying to move beyond and figure out how to reorient our services. Next slide. This is just one of the many factors that we think about when we're trying to create population health. If we can invest in healthier kids, we will have a better opportunity to have healthier adults. But those disparities, unfortunately, start very early on in life. They start with interventions around poverty, around infant mortality, around literacy, that then carry forward into adulthood. And I think this trajectory is where we're trying to figure out where there are levers to invest in community health and health equity. Next slide. What we also know is that if you look among all of the social determinants of health, having higher levels of education are more predictive than any other preventive work that we do, that I do as a primary care physician. And that really is where, in some ways, we have to start looking at equity and our investments differently. But it isn't typically from the healthcare dollars, not typically from the health system, where we decide who is monitored and graduating from high school. We have yet to figure out how to embed grades in our clinical vital signs. We aren't yet asking at every pediatric visit, how are you doing in school? How are things going? Do you need support? How is your mental health or behavioral health affecting your ability to concentrate and be successful in what you're trying to achieve? But we know this is one of the most powerful levers to achieving health equity and to achieving better health long-term. Next slide. What we also know is that we're trying to figure out how to invest in these interventions. And for our health system, it really means rethinking our multidisciplinary teams. And you've heard eloquently how we need to go beyond and thinking about what the healthcare team needs to be. And it has to include these other elements of health workers, people who are in the communities of the community, who are helping everyone navigate our complicated systems of care, where we're thinking about behavioral health integration and all of these touch points, whether it's in the clinical setting, in schools, or other community settings. That is one place where we can invest. That is one place where we can measure what we're doing in terms of health equity, because we can redistribute where those team members are in geocoded, informed areas of need, and those areas where we are seeing health inequities. But we also need to understand that we do create the problems, and I think that's why understanding the data and having data infrastructure and investment to measure what is happening, to create dashboards at all levels, dashboards that are informed by both what's happening at the community level. As a former state official at the state level, that would have been incredibly valuable, not to have to build it all during COVID. But we also really wanted to figure out from the health system perspective, what we're doing in terms of creating a patient equity index. And that is a journey we're on. We are having many challenges with just making sure we're collecting accurate race ethnicity data. But I think that investing in that, standardizing it, incentivizing it, providing flexible dollars would go a long way in terms of having equity focused quality improvement. We also have a skill set to learn around quality improvement and data that is informed by those who know how to manipulate and how to really understand equity and health disparities. There's a lot more work we also need to do around measuring bias and providing assessments at the clinical level, where we can provide that as a feedback loop, a learning opportunity to make sure that we're understanding discrimination, we're understanding differences in referral patterns and service, we're understanding what happens in clinical encounters, and figure out how to do that at a practice and specialty level. It may be different in primary care than it is in specialty care. It may be different in the OR than it is in some of our subspecialties, but I think that and building it in is critically important. Next slide. We also know that Nemours and other healthcare entities have a unique role and need to see themselves as partners. We can't do it all, but we can be strategic partners. And more, I realize that partnership is both a unique opportunity and can be incentivized through ongoing engagement and cooperation through a participatory framework. But I think it is unique and hasn't necessarily gone as well in all communities as we would like. But these are just some considerations to help facilitate and keep accountability with both the healthcare institution and the community on equal playing field. One is through community needs assessment. And I think everyone does this differently, but having that in partnership with the Department of Health, not that is just healthcare driven, is critically important. We also need to think about how to create a health equity index and dashboard where you're also able, as Dr. Cohen mentioned earlier, to create kind of a closed loop social determinants of health referral system that can allow for transparency, can allow for better navigation, and it also allows community-based organizations to put their best foot forward. And I think that is something that we're trying to figure out how to invest in, but is something that we're coming out of COVID knowing that is critically important to closing gaps and incentivizing equity. We also know there are evidence-based programs, and these evidence-based programs often aren't used and leveraged in the right way. It's complicated to braid and blend. It's complicated to create social impact fund infrastructure. But if we can do it along the lines of evidence for home visiting, obesity, and hypertension management, we would create a lot fewer inequities. I won't talk much about community health workers. You've heard about that as critically important. But I think the other areas that we really need to figure out how to close these gaps is around school success, around making sure that we have access to healthy food and healthy, affordable housing, because those are underpinnings that create structural racism, but also are an opportunity to improve and work with community partners. Next slide. So one of the things that Nemours was very interested in doing is looking across the nation around value-based payment models, and specifically looking at pediatric models. And so we did a bit of a convening, next slide, with the Duke Margolis Center and found these key challenges. You can advance on all the bullets. What I think is not surprising to this audience is that what we found is this under-resourcing of community organizations, that there were wrong pocket issues, especially around kids, and we needed a longer time horizon. We needed to look at not a 3-year time frame, but rather a 5 to 10-year horizon where investments early on pay off. But that payoff and that ROI needs to be evaluated longer term. We need that flexibility, and that's partnership with federal and state policymakers in the future. We also need to make sure that we have this opportunity to focus on kids and focus on families. And that is a new way to think about the whole person. It's not just about what happens to this individual child that's in front of me, but how do I deal with grandma and auntie that are all interplaying with each other around health and behaviors that might be influences on these health disparities in communities of need. We're also really struggling with the idea of, where is value-based care? I think as many experiment and try things out, the frustrations that may occur can lead people to go back to the old ways and say culture's too hard to change, and docs have learned what they've learned and aren't going to try to revisit that training. I think that is something we're going to have to figure out and find early wins along the way that really help providers and health systems and partners change the way that they think about equity, that they think about engaging with communities, and the way they think about whole person care. I think the other thing goes back to data around how we measure holistic health, holistic for a family, holistic for a child, And one of the most frustrating conversations I have in my day-to-day is that it's not just about providing care for this 5-year-old in front of me, but it is about the whole family and what they need. If there's a behavioral health need, I probably am going to have to ask what's going on around that child and how to intervene. And I think that's one of the reasons why having a holistic view and a primary care centered approach is critically important. Next slide. So I think there are state level highlights. And what we really found in this review is that some states are figuring it out and incentivizing ideas, mostly through MCOs, mostly through Medicaid. Certainly was how I spent a lot of time at the state level, thinking about how Delaware Medicaid could incentivize social determinants of health and risk and equity. But we have a lot more work to do. And I think there are other ways, particularly now with dollars in the American Rescue Plan, to consider how to invest in health equity zones, to consider how to engage communities and creating one-time investments that allow you to navigate the social determinants of health. But then that one-time investment could carry forward into a long-term position where we really think we're emerging better than we are at present. Next slide. So I think these are areas where we just have a lot more work to do, and an idea, and I hope out of this meeting will call attention to the need for national programs on innovative financing models that allow this work to proceed more quickly, that we think about quality incentives that are aligned around inequities and primary care investment. Next slide. And just to end, I think maybe these are more questions than answers. You know, what if we started out with this equity conversation around improving community health that really focused on things that are atypical in medical care, that are about maternal depression at birth, or measuring vocabulary at age 2, or kindergarten readiness at age 5, literacy at age 8, and then incentivize it and invested in it? What if we invested in the data and the systems to uncover these inequities, and we were okay as medical providers and physicians to say, we are going to have hard lessons to learn and an ongoing journey around our own biases, but that will make us better and will provide better care? What if we put upfront PMPM funding into measuring the effectiveness of a variety of new equity-based interventions and just figured out what worked where and try them all out? I think that that is the question that we need to figure out. And finally, I think this last one, as a recovering state official, it just is dear to my heart, around using the COVID pandemic to reinforce our need to invest in equity, but also refocus on population health. That we know that we had health risks because we weren't able to invest in those social risks and those social factors. And we need to emerge from this better able to handle that for the future and beyond. Thank you. You can take my slides down.